continue and I think make it possible for us to be in a place that's so beautiful and feels like such a special place as Liz. And I think thank them for the stewardship that they gave to this, have given and continue to give this land and its waters. So, Arthi, do you want to come up? Are you ready to introduce? Okay, so Arthi is works with the Population Health Initiative, and she's going to introduce our speakers.
Thanks, Leah. Thank you all for being here. Raise your hand if you've had technical difficulties in the last year before your computer. Yes? Okay. Thank you for being so gracious with us and patient. Figured it out, and we got everybody on Zoom, and hope you're able to hear us and be present with us. So I'm so excited to see a room full of y'all here to honestly hear one of my favorite teams. Wei Chao, I've known since I started my role. I'm an assistant director at the Population Health Initiative, and Wei Chao has received several different pilot awards since 2018 and has expanded her work into various different cultures and languages and aspects, both in Chinese as well as Latinx communities, and kind of figured out various different ways to expand the current work that she's doing to meet needs of different communities that she has relationships with. Wei Chao is from UW Tacoma, so she drove all the way from Tacoma to here. Thank you for doing that. She's an associate professor in the School of Nursing and Healthcare Leadership. And Ling is Wei Chao's teammate, along with Priscilla and Serena, who are unable to join. And Ling works in this building, I learned, which I did not know.
What? Used to.
We used to work.
During graduate school here, you know.
Okay, lovely. Used to work in this building and is an assistant professor as well in the School of Nursing, and specifically from Florida, right?
Yes.
Okay. And I'm really excited to welcome them both to share the work that they're doing on this current work around multicultural, multilingual work around caring for caregivers and how to meet the needs of those communities in regards to mental health and care. I'll leave it to you both to take on, and we're excited to hear from y'all.
Thank you. Thank you. And we're very thrilled to come and share our work with you all. I'm Wei Chao. Ling just graduated from UW with her clinical psychology PhD. So congrats. And she started a faculty position remotely at FSU. So that's why she's able to be here, but her appointment is in Florida. And then we have Priscilla and Serena, who are key members of our team, but they unfortunately can't come today. But Priscilla does a lot of the work in the multilingual, multicultural aspect, which I will be presenting for her. And then Serena does more of the technical aspects, and I'll be sharing that. But they're welcoming folks for direct questions, if any, for them as well. So we're going to get started. And today we're going to kind of have two parts of our presentation. One is kind of sharing our previous 6 years of work in developing COCO. We started with the role-based one, and then now updating it with the new generative AI side. And then the other part of our work started about 3 or 4 years ago is the multilingual and multicultural aspect of COCO. Some backgrounds. Our work is grounded in the context of family caregiving. There are 53, that was data 2 years ago. We're thinking it's probably up to 60 now million family caregivers in the US. They are the backbones of our healthcare system, right? As we push more and more people back home for care, right? Reducing the length of stay in the hospital, more and more family caregivers are taking on the care for our loved ones. 3/4 of the US workforce are family caregivers, right? They're either raising young children or caring for their elderly family members, or doing both, where we call it the sandwich generation. And these people, the majority of them actually, the number one need that they reported is how to actually take care of themselves. So our team started work in exploring what are the possibilities of supporting these busy family caregivers who, if they have any resources, whether it's money, time, they want to give it to their loved ones, right? So what is left for them? If they have 5 minutes for themselves every day, what can we do in that 5 minutes? So about 6 years ago, we started to develop COCO, standing for Care for Caregivers Online. We were imagining a chatbot-based app that supports family caregivers. And what you're seeing here, the design has gone through iterative testing and things, very simple because caregivers shared with us with their overwhelming life. They don't want anything that complex. They don't want, we were, earlier in the days, we were designing like streaks for them to complete tasks. And they're like, no, nothing. Like I only need one button to help me feel better. And so that's why you're seeing this very simple design. There's a few key features that we developed for COCO, including daily check-in, so they can chat with COCO anytime. They can track their health, whatever they did, and then they can have tailored caregiving resources. And then on the left screen, you see here is a chat screen. That's the key feature. And we started with delivering problem-solving therapy for family caregivers. As you can see here, this is an actual conversation happening with a caregiver. It was different from a lot of the button-based kind of role-based customer service bot that we used to see. Now they're improving, we'll get there. But so our team were striving to kind of improving the empathy of a bot delivering and kind of making the bot, making the caregivers feel heard of their stories and then providing therapeutic conversations with them. And our clinical psychologist here, Ying, later will talk more about the content development, the intervention aspect. So we started in 2018, went through the pandemic. RT and I met a long time ago over Zoom, right? So I feel like it was after maybe 3 years, finally we met each other. But our team has been receiving a lot of support from Population Health. Actually, the initial COCO project started with Population Health. So we felt like this is our home. About 2 years ago, you see all these news about the generative AI, GPT, and all of that. So our team also started to look at, okay, how do we harness the power of the new generation of the large language models and use it in healthcare or psychotherapy, but more carefully, because you probably see a lot of news about without intentionally using it, there might be harms. So we don't want to have that. And I just have a couple of slides about kind of the background of all these terms. You probably have heard about AI, LLM, NLP, and all of that. This was a slide that I learned from a speaker that I thought it kind of laid down very visually clear about what is kind of the overarching umbrella term of AI and what it kind of entails when we're dealing with like data, tabular data, especially. It's usually machine learning. And then if we're doing work in language, right, text, it usually is under the realm of natural language processing. And then there's also speech, visual, and things like that. For us, for our team, we mainly focus on NLP, so natural language processing. And then the term large language models, LLM, means kind of this neural processing or natural language processing of large amount of data. And because of that big amount of data that the models are able to process, then it's called LLM. And then when it's generating new text based on these models, it's called generative AI model. So those are coming from a nurse, so take it with a grain of salt. That's my understanding of it. All right, so for us, I'm going to just talk a little bit about initially how we were kind of addressing or developing these technologies and then how it evolved. So natural language processing it takes languages to translate and into like standardized computer instructions. And so teaching computer to understand language and speak language, there's a lot of challenges. There's abbreviations, jargons, and things like that. We all know if we were learning a second language, right, it kind of helps us to see how if we weren't born in a language environment, there's a lot of things that doesn't come naturally, and think of the computer as learning a second language. So here is a actual sentence or sharing from a family caregiver. So a mom of a child with autism shared with us that I was short with my daughters because they were not ready to go to school when I asked them this morning, right? So when we read the sentence, we already know what's going on, things like that. But when we teach the computer how to understand it, there's a lot of things that we need to teach the computer. We'll start with the subjects and the events, right? There are the moms, the mom and the daughters. The events was what happened this morning. And then there's some things that's not obvious from the sentence, but as a human being living in a cultural context, we kind of can assume there are things happening, right? The feelings, and potentially because we're doing health interventions, the potential health goals that we can suggest. So those are things that we need to teach the computer. So here are the subjects, events, and potentially the feelings from the parents. From the mom is that they are probably overwhelmed, right, because of what happened this morning. And when they shared this with us, they were probably a little bit guilty that they should not have been, kind of being short with their daughters, right? So then we would suggest a health goal, right? So here, and those are actually things that Lee and I worked on for a long time, that we collected a lot of caregivers' daily challenges. And then we used at that time a NLP assisted kind of coding structure to help us group those challenges into different categories. And then based on each category and subcategory, then we write a response that would fit that. And then we teach the computer, meaning we train the computer to learn that and how to respond. So that was the previous 4 or 5 years of work of what we were doing. And then generative AI came. It's not like it came all of a sudden, right? Like our work was based, a lot of the models we were using were transformers and the BERT models, which is the structure and models before GPT and a lot of the other generative AI models right now. So when that came, we feed the same sentence and asked, I think this one was GPT, and asked, how would you respond, right? And here is the response. This was from last year. It might have changed a little bit since then. I'll give you a moment to review this. What do you think? Is that good? Folks are like, yeah, it's pretty good. It's a good start, right? It might be overwhelming, right? Like it's kind of dumping everything to you, right? What's the difference between this and an article about self-care, right? And we all know we need to sleep well, we need to process our emotions, we need to eat healthy. What do we do, right? So there's a difference between cognitive understanding versus behavior, right? So what we're still trying to do is changing behavior, right? So from cognitive understanding to behavior. And can we use the bot to help to do that? All right, so I'm gonna hand it over to Li, and then she's gonna kind of explain the process of developing Coco, the role-based one, so regenerative AI or LLMs, and then moving to the current.
All right, so we're gonna take a step back because I think history is our best teacher. Just kidding. Anyways, so 4 phases, from phase 1 to phase 4. Phase 4 is where we're at right now. A lot of exciting stuff happening, which I will introduce later. But starting with phase 1, Okay, so this is where we actually laid the foundation of COCO, based on this therapy called problem-solving therapy. This is a very structured, protocolized therapy that's evidence-based as well, aiming to help caregivers to explore the problem and brainstorm solutions together. So here is the 7 steps that COCO follows to guide conversations with a caregiver. So starting with, of course, to build a good relationship, because that's the foundation of all. And then second, explain what's to expect, right, in the conversation with COCO. And then third, trying to get into the nitty-gritty of the symptoms, the challenges these caregivers are having, and some common ones are anxiety, worry, feeling like logistically challenging, overwhelming, managing everything in their life. And we also assess, for example, for anxiety, how frequent you feel anxious, in what context you feel anxious, etc. And based on these symptoms, we then ask them to generate goals, right? So if you were to be free from anxiety, if you were to be free from sleep issues, what is your goal in your life? What is your goal? To be a mom, to be a good mom, to be a wonderful employee, to be a wonderful daughter to your mom, etc., etc., etc. So these goals are individualized based on the conversation between COCO and their caregiver. So now we have the goals. Next step is to then collaboratively generate solutions. And this is the key part, because just like Wei-Chao was saying, if I just give you a full page of ideas to do, then there's no difference between me giving you like an online article, right? So we really try to customize our solutions through conversation, through knowing the caregivers better. And then last step is to evaluate the solutions. Basically, have you tried it? How did it go? Anything you want to do differently next time? How can we make it better? To make it full circle, so we can learn from our experiences, and then do better next time. All right, actually, before I spoil it, now we have the solutions. Is it enough? Can we just take it and run with it, and life will just be better? Not really, because there'll be times for every one of us here who probably there will be times when we know there's something we should be doing. We know we should be getting up early and get some workout in before work starts. It just never happens. We know we should be eating healthy, we should be sleeping earlier, never happens. We know the solution, but we don't do it, right? So now COCO knows what to do. This is the what part. COCO knows what steps to do, but how do we elicit behavior change? That's the challenge of a lot of behavior change interventions, including COCO. And that's why we bring in motivation engineering, so MI. MI is a set of principles and techniques combined together to really aiming to enhance people's willingness and readiness to change. Originally, when it's developed, it was mostly used in populations with substance use struggles, right? For example, smoking. I want to quit smoking. I just love smoking because it makes me feel relaxed. However, I care about my family's health, because I do impact them when I smoke with them, right? I also want to be there for them when I get older, so I also care about my own health, right? So there's a lot of ambivalence. There's a lot of in-betweenness that we're exploring. So MI is a wonderful tool for that. Instead of forcing a solution on someone and say, go and do it, your life would just be better if you quit smoking. Would it work? No. Otherwise, there will be no research on that. So MI comes in and do this. Combining together, well, actually, what's MI? So this is the list of principles of MI and techniques. So let's look at principles first. These are the principles that you will usually see in almost all therapy as well. So as I know about MI, it is both a therapy on its own and also a transdiagnostic toolkit for all treatments you do. So no matter you see people do CBT, DBT, all kinds of T's, they more or less use these foundational MI techniques. And when I was trained to be a therapist, these were one of the first classes I took to be trained in, because these are very foundational skills. So to give you one example of how this could be useful for someone who is trying to quit smoking, on the right side I'll give you an example of one technique, for example, reflection, right? So when we say reflection, we're trying to identify, to see through the words and identify the value the person is trying to live in their life. So say, okay, I hear you want to quit smoking. It's been hard. I know it's hard. And I also know you want to be healthy for your family. You want your health, you want your family not be impacted by you, right? Because your family is important to you. So that's one way to use reflection, which is just to say, I know it's hard, and I know it's important to care for your family. So that's the value part. And then the rest you will see the pattern of very quote unquote soft. We never want to confront when we use MI, because confrontation rarely works, if ever. That's what we believe in therapy. Okay, so combining PSD and MI really together, COCO aims to elicit behavior change really by increasing motivation, readiness, and also by providing tailored solutions that we know will likely to work for them, because we talk about it. It wasn't just me giving you 10 solutions and go try it and see which ones take them all, right? So that's phase one. What do we do in phase one other than building this foundational theoretical and therapy framework is we also generated some personas for future phases. So we had 4 family caregiver personas based on literature, based on our could have done workshops with our community partners. We're also caregivers. Together we had 4 personas, and then to represent these common symptoms they tend to experience: worry, anxiety, fatigue, sleep deprivation, tiredness. And then based on these personas, we then developed dialogues for 2 PSC sessions, 2 sessions for each personas for total. And these dialogues were developed by our experts in our team, who are either nurses or clinical psychologists. Okay, so that's phase 2, building upon phase 1. In phase 2, we then the goal of phase 2 is to collect natural dialogues. Remember the first phase, we were just creating dialogues based on these personas, right, within our team. But on phase 2, we actually try to engage with what we call standardized patients. So we hired actors to act out these personas, right, to pretend they're injured, pretend they're worried, they're tired, and then engaging conversations with Coco and see where the conversation will take them. So in this particular study, or a series of studies, we use this approach called Wizard of Oz. It's like what you're seeing right here. The trick is, if I were the standardized patient or the user on the user end, I wouldn't know what's happening on the back end, right? Because I'm just looking at a computer screen. But what's happening is I thought I'm talking to a human, but actually in the back there's a wizard. The wizard in this case is a clinical team member, a nurse or a psychologist, right, to provide the responses to your questions, to your input to the bot. So that's Wizard of Oz method. Through this methodology, we then collected some dialogues. I think it's 4. I'm gonna skip numbers. It doesn't matter. So I had 2 personas and 2 standardized patients, so 4 dialogues in total for each PSC session, so 8 dialogues. For these 8 dialogues, we later then coded for the number of MI techniques, which I will showcase later. But for now, I just want to highlight that even with this simple, I guess, Wizard of Oz method, where there's a human behind the scene, we did collect some preliminary user experience positive feedback. So people, well, in this case, it's then as patients, actors, did say through this conversation, based on the persona they were performing, they did feel supported by Coco through this conversation. And they also found Coco overall to be kind of pleasant. Obviously, who won't talk to someone who is always aggressive? Sure. Not really, not me. And so they found Coco to be informal, to be very easy to talk to. And they also prefer to receive solutions from Coco directly rather than having to think hard on their own to generate their own solutions. Which I think we took that as a feedback, and then going to the future cycles of design, we were more intentional in providing a couple of different solutions that based on what we know about the caregiver, so they can choose from it rather than just say, what do you want to do? Because they're already overwhelmed. Sometimes it's hard for them to then think about what to do. And then flexibility, on-demand support. This is always nice. I mean, think about it. When you're in distress, you want to pick up the phone call and just call a friend. Isn't that nice? Same thing. So when they're feeling stressed out, they feel like when there's something, someone above they can go to, it's very comforting to know there's someone, something for them, supporting them 24/7. And also flexibility, right? Caregivers is busy. They're managing their life, their kids' life, their parents' life. So having a bot there, a support there, that they don't have to schedule in, is very, very valuable for them. So that's phase 2. Going to phase 3, so you will notice that we're evolving in terms of who we are using as our testers or evaluators. So in phase 3, we did this feasibility pilot study with actual caregivers. In this pilot study, we aim to examine COCO's usability, preliminary efficacy, and improving caregivers' emotional well-being. So for this purpose, we recruited participants who were caregivers of a child with chronic illness, who speak English, and also have internet access because our study was conducted online over Zoom. So what they did is they received 2 PSC sessions over Zoom using the WODS method I presented earlier. And then it's a single group pre-post design, meaning this group of participants who were enrolled in the study received baseline measures of their emotional, the measures out there of their emotions, emotional status, and then afterwards they also received the same measure to see the pre and post change. Okay, so these are the people who were involved in the study. There were 32 of them, and then the majority of them were female caregivers. Then top 3 diagnoses of the child were arthritis, autism, and diabetes. As you would imagine, managing these conditions can take a lot of energy, and a lot of these sometimes require close monitoring as well, and frequent doctor visits. Not surprising, people are experiencing stress and anxiety all the time. Okay, so for this study, we collected qualitative data on user experience, where they reported, well, they found the responses helpful, but it's kind of slow, and sometimes they feel like the conversation was not flowing quite well. Again, despite all of this, the COCO did receive a relatively good usability score, 76%. And then in terms of the effects on their emotional status, it's definitely promising here to see that we saw improvements in negative affect, including sadness, guilt, and fatigue, meaning some weight was lifted off them, which is nice to know. Especially it's only like 2 brief sessions with PSC. Imagine what you will see if you do more of this, regularly every week. And then also increasing serenity, so like feeling more calm and less anxious, and that's wired up. Okay, so exciting stuff. Phase 4. This is where my passion is at as well. Okay, so LLM-powered COCO. We developed this GPT-based COCO. Still, we have integration of PSC and MI, and we use few-shot prompting to infuse a model with knowledge base with the examples of using MI in dialogues so that we can guide these foundational models to talk like a therapist. Because we all know these models are super, super smart in the sense that they have so much knowledge of everything, but they don't necessarily know how to use it. So this is one way of teaching how to talk like a therapist. So in this small study, we had 2 team members to interact with the LLM-powered COCO, and then we generate 12 dialogues, and then we code it again for the number of MI techniques to compare with the previous generations of rule-based COCO, which I will present right now because I think it's very exciting. Okay.
Can you tell us what few-shot prompting is?
Yeah, so the large language models that are off the shelf, they have a lot of knowledge. They were trained on massive data, but they might not have the context or what we say domain-specific knowledge, right? So then there are a lot of techniques to train it to learn more about, in this case, what COCO does. And the very the easiest ways to train them are a group of techniques called prompt engineering. And then within that prompt engineering techniques, there's the zero shot, few shot, chain of thought, all of that. There is a paper that we're going to talk to in a little bit, and folks who might be interested can review more in the details of that, what we did. Hopefully that helps a little bit.
Okay. So this is a review of for the past 4 phases from phase 1 to phase 4. We'll navigate through the columns first. So that's each phase. And then each column is just the number of my codes and the dialogues reflected. And then each row is a type of MI technique, right? So there is collaboration, there is questioning, there is reflection. So what do you notice? Oh, and by the way, I circled the top 3 or like the top most popular techniques in each phase. But just like quick scan right now, let's see, intelligent audience here. What's your observation? Any patterns?
You have more that came through on the large language model.
Yes, of that. Yeah. Anything else? So more variety of techniques will be used. Yep. Yes.
Seems like the MI is just the lowest during phase 4.
What do you mean by lowest?
Simple grounding.
I see. Simple grounding one? Okay.
The simple grounding, which is, I'm sorry to hear that. Oh, thank you for sharing. Those are reduced because they use more of the top, more complex ones, right?
Yeah, exactly. Simple grounding, you can think of it as like when you're talking to your friends, you're like, oh, I had a tough day, I have so many exams. You're like, oh, that's hard. Oh, that must be hard, like more validating, but it's like that simple grounding. So it's more like a default fallback, easier if you think of it that way. So definitely like both of you were observing this. For simple grounding, you can see from left to right. So it decreased from 28 to 6%, which basically says that the model in phase 4, we're using more and more advanced techniques in MI. Versus before, even though it was human who were involved, who were experts. Does that make sense? We were using more kind of simple and foundational rather than when we taught La model, the same thing, same set of techniques. They were able to just quickly grasp and say, all right, I see all these opportunities to use all kinds of different techniques. And here we go. That's what we saw. I know this is a little pilot study at the same time, like pilot study for phase 4, but we see some glimpse of that potential. So there's that. And then one last thing I want to present here is also comparing phase 1 to phase 4, but this time I want to basically showcase how on the COCO side, so we are evolving from human to GPT, and on the testing side, we are trying to use, we're trying to stick with more and more kind of human interactions rather than using like standardized species. Makes sense. I guess I want to highlight here is the last column, the average number of MI code per turn. Again, I circled those 2 numbers because as you will see, I know the numbers are kind of close. At the same time, the model that was based on GPT had the highest average number of MI techniques per turn of dialogue. What's your take? How do you interpret this? Yes.
I'm just wondering, is higher better? Is it better to use more techniques?
Ooh, that's such a good question. Let me think. Well, in general, I would say yes. Because a lot of these techniques, if you think about it, the more you try to use it, the more like targets on the behavior change you might be hitting, right? So it's always good to be flexible in what you're using rather than just using one all the time, right? Or like just not using any, which won't really be helpful for behavior changes if that's your goal, right? So I would say yes. And based on my answer, what's your take? What's your interpretation of this result?
Well,
I don't have any error bars on there, so I don't
Sorry?
know. I said there aren't error bars, so I don't know if it's significantly different.
Exactly. I don't think we didn't do a test, yeah. But I guess
it looks like similar as, but and maybe a bit better.
Yeah, like qualitatively. We're seeing like it's like more efficiently using MI techniques. Like this is in line with what we see here as well, right? They're using more variety of techniques, and they're also doing it more efficiently. They're using so many in only 12 turns of dialogue, right? Basically meaning during conversation, this bot was able to see, oh, here's where I can use MI, here's where I can use MI. And it was able to quickly identify opportunities to make a change, to make a difference. And that takes a human, maybe a year or two, if you're talented, 6 months at least, to learn that, to see, oh, they're talking with a client, here's what I can say, maybe apply this technique to shift behavior into like more and more change direction, right? That's not easy to do. For some reason, with simple prompting, LLM was doing a good job, relatively close to human from the first phase. But let's wrap it up so we can move on to more exciting stuff. Okay, so basically, again, review phase 1 to phase 3. We laid the foundation of Coco, and I can't emphasize this enough because for all the bots in the world right now, what I really feel like my real feeling is, what I really feel like I'm looking for when I look at the bots is, where is your theoretical foundation? What is your bot based on? Because I'm all about evidence-based treatment, right? So I think with Coco, we really did a good job with building the foundation of Coco to make sure we're actually delivering evidence-based treatment with the techniques we know that's been working clinically. And then phase 4 is a proof of concept, and then we're having more and more studies under the works right now. So overall, we do see some potential for AI in mental health. As I said earlier, we see this quick replicate and application of these techniques in a pretty quick and small pilot study. And then the bot was able to engage in empathetic conversations, was able to really utilize these techniques pretty flexibly and efficiently. Okay, but here are the buts. A lot of buts. A lot of these, if you are familiar with these LLM world, probably won't be surprising to you coming up. But first off, contextual understanding is so important. As a clinician, we pride ourselves in doing thorough assessment. We don't just do it one-off on the first day. We do it every single session because your client changes all the time. We want to make sure our treatment protocol or whatever we're recommending, advice we're giving, or even the way we talk to you is being tailored on a regular basis. So that's something that Coco, we're trying to explore more as well. How can we do more thorough assessment? And one thing we're trying to use is called chain analysis. It's a technique from DBT, so dialectical behavioral therapy, developed by our own Marsha Linehan at UW. Basically exploring, say if you have a behavior, have a symptom you want to change, I'm going to unwrap them and go back all the way to how it started and how the thoughts and emotions and behaviors all chain up together, lead to your eventual problem behavior or symptoms you're trying to address, either decrease or increase. So that's basically what we say. What we mean when we say contextual understanding is we want to know what's been going on inside your head, and also externally in your environment. Because knowing that will help us identify more opportunities to change it, to intervene, right? So leveraging those contextual information. And then second, without knowing these contextual information factors, AI can be harmful. And I'm sure you have seen uses here and there. Just give you one example. I've worked with patients with eating disorders before too. And so thinking about them, right, I'm afraid they would just go on and ask, well, I want to stop, I want to eat less, tell me how. I want to lose weight, tell me how, right? LLM doesn't know my client has eating disorder. It does not know my client already has these maladaptive cognitions around eating, on food, or on exercise. I mean, LLM will just be agreeable and be helpful, be like, oh yeah, here are things you can do, 1, 2, 3, 4, 5, right? That's the potential harm that we all see as clinicians LLM is capable of, and how do we prevent and mitigate that is again, a lot of assessment, a lot of regulations as well, right? If we're developing a tool for vulnerable populations or clinical populations, how do we prep the system to prevent these harmful advice to be given from this LLM? And then third point, which is actually related, is LLM has difficult time acknowledging its own limits. Like it's not aware of, for example, biases, right? It's not aware of its lack of cultural competency. There's plenty of literature revealing the racial biases of these LLMs, which is not surprising because it's trained on these data in our society, and these data reflects how our society right now is functioning. The LLM obviously was taught by the data, so it's exhibiting a lot of the biases as well. And so, going to the last couple points, user privacy, data security, of course, has been an ongoing conversation where you're talking about where is it going, where are they going to use the data, et cetera, et cetera. And then last part is if we're going to continue to develop these specialized chatbot for a particular population, how can we involve more experts, involve nurses, involve social workers, involve clinical psychologists to actually make the interventions evidence-based, make it theoretically solid. And so we were talking about this in one of our papers. Well, for example, in development stage, we involve our experts to develop these prompts, like Rachel was saying. We don't just let's just write it out randomly and then see how it goes, right? We actually go back and look at the clinical manual and see what is our clinicians doing in the world, what's working, what's not working. And then another stage where experts can come in is evaluation, right? When we are looking at these models, in the end, there are frameworks clinically we can use to thoroughly evaluate how a bot is working in a therapy session. For example, there's these reading skills to assess the rapport building in the therapy session, the goals, was the goal being addressed, did the client feel a bond with a therapist, etc. So there were a lot of different frameworks that we should use, and we should think more. We could also probably adapt them, right, to these chatbots to more accurately evaluate their performances in mental health setting. So that is me, and then I will leave Wei-Chao to review the exciting stuff that's been going on and what will be happening in the future. More.
Thank you, Lin. And thank you, Lin, for summarizing what we did in the past 5 years. A lot of work, and then this was just the paper that I mentioned that we recently published in looking at how to do domain adaptations of LLMs in the psychotherapy context. Very preliminary work. This one we did expert evaluation, kind of as the same phases that we did with the role-based COCO. We're repeating it much more carefully this time, I feel like, with the LLM-based one. So this one we did 7, half nurses and half clinical psychologists evaluating them. And then we improved the models based on that. And now we're doing a study. We're actually inviting caregivers to have the conversations while we monitor on the back end, always, just in case anything happens that we can intervene immediately. And okay, so that kind of wraps up the COCO development. It's obviously still ongoing work and repetitive, iterative testing always. And then since the LLM came, for someone who is bilingual, I'm always curious, how does it do in a different language or different context, right? So in the context of the States, more than 1 in 5 caregivers speak a language other than English at home. And those are the people who actually need more support because they have very limited access to tailored support for them. So can those large language models, which claims that they are trained in, let's say the foundational BERT model was available in more than 200 languages. So how could we use those technologies to provide more support, linguistically sensitive care to these caregivers? So initially we did just an initial kind of experiment. I think this one we tried Gemini, but across all the different models, their performance are similar, right? So we asked the same question. I'm taking care of my son with autism. I'm tired. What would you do? And here's the standard answer, pretty similar to what we shared before. And then we asked, I'm a Mexican American. Initially, you see the prompt at the end, I asked, what would you say to me in English? If I did not put that in, it started to respond in Spanish, which comes in an inherent stereotype that if I'm Mexican American, if I'm Chinese American, my language would be the original or whatever ethnic language I have, or the assumption, the bias could be that I don't speak English well, right? Which is not right, right? So you can see, so then we prompted, what would you say to me in English? So then the bot responded, oh, I totally understand as a Mexican American, you have these feelings. But then if you look closer, it's the same, right? So the bot is trying to portray that they understand, but at this point, actually no. And this was a paper from last year, but it still applies. The Ghost of the Machine has an American accent. And we don't want that, or at least in therapy, we don't want to build something like that. So then our team, we wanted to look at how can we culturally adapt or improving the cultural relevance of a therapy bot. So the importance of cultural sensitivity in mental health chatbots there's a lot of literature showing or stressing the importance. So I'm just highlighting a few over here. And then the LLMs that we are examining now has cultural biases, like what I shared a simple example before, right? So it has it lacks cultural sensitivity in a lot of different aspects. I'm not going into the details here, so there are some references that we highlighted here that you could look into more. So then we as a team are looking into how can we address this? How can we train Coco to better develop or deliver culturally sensitive and linguistically tailored care? And here I just wanted to highlight a couple of concepts here that we're working on. One is cultural adaptation of evidence-based intervention, the EBI. Those are the problem-solving therapy, the motivational interviewing that Ling was sharing. So the cultural adaptation of it is a broader term. It kind of adapts every aspect of an intervention. And then within that, there is a sub kind of area that we are starting to tackle on. So we can't do everything for cultural adaptation. We're starting with culturally aligning LLMs with different cultures. So that's what we're starting our work with. So we're aligning our AI systems with the set of shared standards and beliefs and values in different cultural contexts. And also, I wanted to just share that the work that we're doing is very narrow. I wish we could do everything, but we picked very narrow areas to define culture, right? And then also, when we say Latino family caregivers, Chinese family caregivers, those are the definitions that we're referring to, knowing that they're not a perfect definition, but those are the working definitions that we're using for our work. So in terms of then, where do we start? We always start with assessment, right? As nurses, as clinical psychologists, we always assess first. So we wanted to first do formative work in identifying what are the cultural adaptation components of, let's say, if we were to deliver Coco for Chinese or Latino family caregivers in the States, what do we do? So we started, again, going back to formative research, and this work was also funded by a Tier 1 grant. So whenever we have a new idea, we wanted to collect some formative work. We're very lucky that UW has those resources for us to get started on projects. So here, I'm going to share quickly some results from the Chinese Coco study. We also did a parallel study in Spanish. So for the Chinese Coco, we collaborated with 4 community organizations within the greater Seattle area that are serving the Chinese American population. We conducted interviews with the family caregivers as well as the community staff members serving those communities. And so we together interviewed 13 caregivers and 21 staff, asking them about their challenges as a caregiver, their challenges, and as the community members supporting these families, what are the challenges? And then kind of coding them, and quickly just some preliminary results of like what we learned. There's those caregiving challenges. There are a lot of self-care barriers, and And then also we asked them about if we were to develop a chatbot to help you, what would you like to see and what are your concerns of them? This work we just presented last week in the Gerontological Society of America that happened in Seattle. So, and the paper should be coming out soon as well. For the interest of time, I'm just gonna go quickly about them. And as also Li Ying shared about, when we do interventions, we want them to be theory-based and evidence-based, right? So when we do cultural adaptations, we chose a cultural adaptation framework to help us ground our data in. So this is a cultural adaptation framework, CTAF model that we use. So then we looked at our data and put it into where do we culturally adapt in those different components of a evidence-based intervention. So just an example of one component of treatment delivery of COCO. There were data showing about the bot needs to use cultural expressions and sayings, including cultural examples and themes. So then those are things that we're gonna align our LLMs to have a better understanding. And then we did a parallel interview with the Latino family caregivers. For the Latino one, we have a collaborator, Dr. Maggie Ramirez, who has done this work in Latino family caregivers for a decade. So she has some preliminary work. So then we're building on that. So we don't want to reinvent the wheel whenever we have data. So then we ask some more tailored questions about adopting it in chatbots. What can we do? So it's ongoing. We have interviewed about 18 families. We're also hoping to interview some community members as well, kind of getting their perspective on that. So after the formative work, then we need to think about technology-wise, how can we do that, right? As I mentioned, most of the LLMs are based on the transformer models and the BERT models that are available in like 200 plus languages. And all of them can answer a word value survey question perfectly, right? Because those are the data it was trained on. However, being able to answer questions about a word value or a different culture doesn't mean that in delivering therapeutic conversations, the bot are able to do that. So that's where we need to do is aligning the cultures when we deliver therapy bots. So here are the, going back to the kind of the technical aspect, in terms, when we think about training large language models in a specific context, we call it domain training, or training a specific domain. There are two main groups of techniques. One is not changing the weights of the models, how like the data are talking to each other. And then there are the categories of changing weights. Today, we're gonna start with the not changing weights. So those are the prompts. So like giving the bot, telling them with simple instructions. Those are the simplest ones. And then there are some more complex ways of training it, such as the middle one, RAG, retrieval generated augmented generation, means that we're giving it a document. Let's say I have a dictionary of Latino sayings, and then you asking the bot to use that to refer to that when delivering context. So the initial one that we're starting is called cultural prompting, right? Very simple. You're talking to someone from this specific culture, make sure that you use the references that we're providing. And there are multiple, more complex than this. I'm just giving a very simple example. And the way that we're developing the bot is a technique called multi-agent training. So it's a state of art of using LLM in specific domain adaptation. Basically, my understanding, again, from a nurse, is that if we give, let's say, 5 pages of instructions to a bot or to a model, it can't comprehend that. But we can take 10 different bots. Each bot, I'm just telling it to do one task. And then we're adding the bots, so building a team of bots, and they can work together to make the response better. So here is an illustration of, let's say, a caregiver wants to talk to COCO, And this one, the therapy agent, is the one that we've been developing for 5 years, right? Like making sure it's empathetic, making sure it's delivering problem-solving therapy, motivational interviewing, chain analysis, and all of that. And after this therapy bot generates a response, we're not sending it back to the caregiver yet. Then we're circulating it with other expert agents that has, say, one agent knows all the information that's tailored to Latino caregivers in Seattle. The next bot adds all the cultural themes or modifies that. And then there's another bot or agent that can add sayings and expressions to it. With all the modifications or multi-agents working together after that, then we send that response back to the caregiver. So that's the system that we're trying to develop now and testing it to see whether actually culturally aligning the responses makes a difference. And then we'll do the same iterative testing, right? We'll probably start with experts first, making sure the experts are okay with it, and then moving it slowly to caregivers testing and all that. And within all of that process, human expertise are very, very important. So we always have a very robust clinical team with folks from different clinical backgrounds, making sure evaluating them. So I cannot stress enough how important it is with the human evaluation in those work. And that is a very quick kind of introduction to our team's work. We went for, I think it started in 2018, the project 2019. We started with the initial COCO, and then we have a very diverse team, and we always think about, immigrants and people from different cultural backgrounds. We started with Latino and Chinese, which are the second and third most common language in the States, and we're hoping to do more if the approach that we're taking seems to be helpful, then we're definitely wanting to do more. I also wanted to just say one more thing, that as we look into those work, we feel that Spanish and Chinese are very fortunate as languages. There's a lot of resources that we can refer to. There are a lot of languages that does not have those resources that we're using to train. And how can we make that better? I think it's us people that we can curate those data sets and teach the LLMs to do those things. And so it's very important for us to kind of continue exploring that. And we can't do it without our community partners. So we continue to build, we do a lot of volunteers and in the communities, and actually the initial kind of idea came from community events that they were asking us to do things. So, and then we can't do it, it's not just Ling and I or Serena or Priscilla, so we have a big team. So here is our Latino team or Spanish-speaking COCO team that we were at Casa Latina. I think we did a series of health events in the community. Here's our Chinese team that we did a booth at a multicultural caregiving event locally. And then we also have our other tech experts. So Dr. Martin D. Cook and I co-direct the Responsible AI for Health at UW Tacoma. Our lab mates over here. And then also here is us last week at AMIA, Dr. Trevor Cohen in biomedical informatics, and our teammates presenting our work at the medical informatics conference last week. So we have a big team, and we always work together. We appreciate each other and respect each other's expertise. We always get into fights, but I think those are what keeps us healthy and kind of a robust team. Thank you very much, and we're happy to kind of discuss with you all.
I have a question around culture, but also really around culture and rhythm and timing of language and just the notion of efficiency, right? So it seems like as you were talking about the number of turns and AMIs, it seemed like the notion is to be productive, perhaps with time. And I wonder if that generates from therapists working with clients having limited time. But one of the things that I would have never imagined 10 years ago is that what used to be long for a movie, like, 90 minutes or 2 hours, now I will happily binge watch something for 6 hours, right? So if, that's the case, the time is maybe different. How do we think about, trying to make efficient progress with somebody through something like this where the therapist goes away? So it's a machine. So, who cares how long it takes maybe? Or like, how do you think about that?
It's a great question, and it goes more philosophical as we kind of develop these things. Lee and I always have this conversation. I always question, is self-care a concept that we need to teach people? Like in my culture, the smallest unit is family. Like I never think about myself, right? Like doing things for my family is for myself. So then if we are telling people you need to do things for yourself, if you're not, then you're not healthy. Would that idea actually kind of influence people? The same thing as we need to be efficient, we need to talk. There is actually, we work with a team in the Foster School on evaluating the therapeutic or communication styles of a bot. And that's where I think this work is relevant, that we're actually, I'm learning so much from that work. We have a faculty member in communication that taught us a lot of cultures have high context versus low context culture. Like in the States, the main communication style is very low context, very direct, right? Let's go to the point and talk about this. In some cultures, some cultures, people never go to the point. We want to talk about everything else. And then hoping that you understand what I'm talking. And we always take an hour to have a conversation. And how does that influence therapy styles? Because now we have potentially that resource to have the bot to be able to adapt to different communication styles. And again, that communication style alignment, or it could be partially the cultural alignment, hopefully can increase the therapeutic alliance. So then the outcomes would be better. Yes, we are also exploring that in a project right now, but very preliminary work. There's so much. I feel like every time we want to explore something else, like there's a lot more. I think part of it, we're very lucky at UW. We're, it's a comprehensive university. We have experts from different teams. So we started that work with the group, the faculty in communication and Foster to do that work. Yeah.
Thank you. That was a great presentation. How do you get past just the mistrust that is with dealing with AI and robots, and how's my data gonna be used, especially with different cultures? And the second part to my question is, do you think the fact that, there's a lot of cultures where therapy or talking about your mental health is stigmatized, so do you think the fact that they're not really talking to a person might address that stigma? Or is that just gonna make it worse? Be like, oh, now I have to talk to a computer as well.
Yeah, great question. So let me see if I can. So the first one about like misuse, trust, and all of that. Yes, I think whenever we're presenting a new technology, there's always going to be that. Our team's approach is we'll try to do the best, right? Like we're using. So a lot of the initial experiments are run on GPT because that was the best performing models, but the end goal is not to use those proprietary models. We're trying Mistral, Llama, and doing parallel experiments, and hopefully in the end, we're going to use an open source model where it's secure and everything for the work that we're doing. Our computer scientist expert, Dr. Martin D. Cook, her expertise is privacy preserving machine learning. So eventually, hopefully, we're going to be able to use her technologies in helping us to be not only able to use the most up-to-date or cutting-edge models, but use it protecting our caregivers or patients' privacy as well. So I can't force people if they don't trust something, but we can tell whatever concerns you have. Let me tell you how we are trying to address it. We also have a data visualization team actually showing people what data you're giving us, how we're using it, and visualize for your benefits. We learned that if people knows that their data are being used in what ways, they are more willing to share. So those are the ways that we're exploring this. Could you repeat your second question?
Yeah, like since you were talking about adapting this to different cultures, how do you think stigma is going to show up? Is it going to help this stigma or make it worse?
Yeah, it's such an important question. So the cultural adaptation framework, there's a whole component of treatment delivery, right? And thinking about culturally adapting the delivery methods, there are a few things that we've tried, like in the Chinese culture and Latino culture, like we don't call caregiving burden. We aren't helping you with caregiving burden. And we always frame it like helping you is helping what you want to do for your loved one, right? So like reframing it, we're not doing a therapy, we're doing a chat, we're doing a conversation to talk about your situation and things like that. So, and then the other aspect I wanted to mention is that for the stigma piece, actually what we're learning is a lot of the immigrants who are concerned about privacy and stigma, they actually are excited about the bot because then it's free of judgment. So they're actually willing to talk to a bot that doesn't come with all the judgment and context of potentially a human therapist. And then they don't need to tell anybody that they're taking a bus an hour to see a therapist. They're at home, they can do it in a private room. So those are the positive side of it, but I'm not denying all the negative side about stigma and things. And again, I think going back to actually the Western concept of therapy, is that actually something that we want to introduce to everyone, right? Like that I'm still struggling myself with. I don't have a right answer. But what we're doing seems to at least be helpful to people who need it. And again, if we're designing for everybody, we're designing for nobody, right? So we have to pick a population that potentially could benefit from this, and we'll start from there. Thank you. Yes, please.
I have a few questions. I think that the first one is that how do you deal with contextuality? Because I think that in general, like mental health is very fluid. So like sometimes you might have remission, sometimes you have bad days. So like, does your model kind of like remember states and have like some sort of memory about how the patient was, how the caregiver state was changing, maybe like underlying patterns? And the second question I think would be like how would you make the study like user-centric? Because so far, I've heard that there's a lot of focus on evaluation from expert side, but caregivers are mostly participants who don't give that much feedback on the system. So like, how would you, I know your view on that would be also very.
Great thoughts. I'll address the second question about the user-centeredness and who other humans or eventually who are using it. We always end with human evaluation, but we start with expert evaluation because from our perspective, it's a safer population to do testing with because they're experts and we're not delivering treatment towards them. So so we always start with experts, but as you might see in like phase 3 and 4 of the initial COCO and the next step of our LLM model, we're testing it with caregivers. So that's always where we end with, and iterative testing, not just one-off testing.
I meant not testing. I meant to, like, for example, experts, they kind of can give you some feedback on what they want to add to the system. And I wondered, like, basically, how do you gather feedback from actual users, from actual caregivers? Like, in what form? Yeah.
I think where we're positioning COCO is an expert care. So we are trying to develop COCO as a therapist to deliver. So we are trying to have COCO to learn therapist behavior. But then we do incorporate caregivers' feedback, but when it's more developed, then we also do that tailoring. Yeah. Oh, the fluid, yes. Yeah. So it's part of the reason that we're developing an app, not just a web-based tool, so that everyone has an account. Then all the conversations are archived within our side of the cloud, protected. And then we also do daily check-in. So we always do repetitive assessments every day, multiple times if they'd like to have a conversation. So those data are always helping us to, when we're delivering therapeutic conversations, making sure it takes account of all the data that they're sharing with us. Thank you. Thank you.
It's quite a great work. I found this very interesting. So I want to ask a high-level question. What's your vision of the end goal? Like, in the end of the day, what be that like?
Yes, the dream would be to have the 60 million family caregivers use Coco, or at least half of them who might have experience mild to moderate symptoms that can use it. They don't have to use it every day, but whenever they need to, they think about this is something that is available to them, accessible. With that aspect, we also have continuously explore with CoMotion, ITHS, PHI, exploring what are the ways for us to kind of making it more available to more people beyond the kind of the research testing environment. So actually recently we got introduced to a caregiver startup company called BeCare. We're talking about doing a licensing out kind of approach to work with them. So there are those explorations as well. Thank you.
You use recorded sessions between caregivers and or clients and therapists as like training, right? I mean, to some degree, there's a question of what is good therapy and what should you be modeling, right?
You mean the actual like sessions where we do recordings? Yeah. Yes and no. We're doing text therapy, right? And eventually there are technologies also for people to speak and then Coco to voice out that. But those therapies are different from if we were doing an in-person therapy. We are using some publicly available therapy dialogues to help us to fine-tune our models, especially now we're getting into the cultural aspects. So like there are large recorded therapy and encoded dialogues for us to fine-tune Coco in, let's say, Chinese and Spanish, where because in those therapies, the cultural values are very important in the context, so we wanted to use those. But in terms of developing Coco, there is a conversation we had with, I think, multiple times is let's say if we record 50 therapy sessions, are those the best ones, right? And like you said, right, like therapies are limited to 50 minutes, and the therapist might not have the similar cultural backgrounds as someone, and so potentially the bot could do better. I think I was in a session with computer scientists, and they were like, we don't want the LLMs to mimic what human does because it's a flawed society with things. Hopefully we can develop something better. We don't need to constrain ourselves in what is happening. So I think that's where we're trying to develop Coco, not mimicking human, but try to do what we think is the best way of delivering it in this context. But we also, beyond Coco, we also collaborate with other teams who have existing interventions that has archival data. Then we try to use them in ways that would make it better. Yeah. Thank you. Yes.
It's interesting, like that Coco is better at implementing like the principles of motivational interviewing than a human is. So that sort of speaks to that last point you made. That I was curious. One of the notes was from the I think the large language model that the feedback took a long time. As you're doing the cultural modifications, and there's so many other bots that it's coming through, is that slowing down the responses quite a bit?
It's in, I don't know, many seconds kind of thing to do that, but it's expensive.
Yeah.
The more agents we add in, the more the term is tokens, like the tokens we like seek the large models to get. Yeah, it gets expensive. So there is a term of, I think, sustainable AI or some similar terms of thinking about what's the most efficient way of using those. Yeah, but because ideally we could create 100 agents that could do really good tasks, but then that's not sustainable. Yeah. Thank you very much. And
mindful of your time.
Thank you. Our emails are here, so love to
Thank you so much.
Thank you everyone for coming, and thank you.
Oh yeah, there is
Question that just popped up.
Yeah, let me see.
But
Yeah, Judy, thank you for that question about long term. We the longest experiments we've done is 2 weeks caregiver, so we'd love to continue that experiment, having people using Coco longer and do more of that long term feedback and examination. So that's to be coming. Yes, to be continued. Thank you.
Thank you. Thank you. Thank you for joining. That's really excellent. So much for coming.